to see how exponential medicine is exponentially growing and thriving. And we're thrilled to be with you for our first live podcast. As Daniel mentioned, we've done 7 episodes. Has anybody listened to any Medicine and the Machine podcasts? A few? Yeah, that's great. And of course, it's a challenge to start a new podcast amidst podcast mania, but hopefully this topic is one that everyone here can identify with. So I think the first thing we thought we'd do, just besides mentioning that you can get this not only through Medscape, of course, also through iTunes, and also to thank Ivan Oransky, who's here, who's really the editor that is so helpful for the whole podcast that we do to keep them straight, and there are transcripts that are available on the Medscape site. So, Abraham, this has been so much fun for us to come together, and maybe we can talk a little bit about how we did finally come together for this podcast.
Yeah, I mean, I think people assume that you and I are on opposite ends of the pole, that you're the futurist, which you are, and that I'm somehow this Luddite, and I think that neither of us knew that was true of each other, but when we met, we certainly discovered that that wasn't true. As much as you are a futurist, you're a very, very traditionally trained and a very traditional clinician, celebrating human values. And as much as I write and talk about humanistic medicine, I'm also, in the crucible of technology at Stanford and Silicon Valley and embrace it all. I'm carrying an ultrasound. I don't use it as well as you do. So I think when we first met, there was this moment of recognition that I think there is something unchanging about medicine, and both of us deeply subscribe to that aspect of it.
Well, and I think if you're not aware, Abraham received the National Humanities Award from President Obama at the White House in 2015. I don't think there's too many other physicians that have been noted like that. And not only is he my favorite humanist, but also my favorite physician author. And I just would go back to, 3.5 years ago, I underwent a knee replacement with lots of complication of it. And I wrote an essay for the Washington Post about the experience to try to teach others. And before I sent it in, I sent it to Abraham to give me some ideas about that. What was notable is he cracked the case about not only was a physical therapist who helped rescue me several weeks after I was in such turmoil, but that she actually cared. And you brought up the famous Francis Peabody quote.
The secret of the care of the patient is in caring for the patient.
Right. And that is a very important next to last sentence in a 6-page essay from 1927 or something like that from Francis in JAMA that you can download. The point here is that we don't believe that AI and medicine are at all competitive. That's why it's medicine and the machine. And so we need the caring. We need all the aspects of what the humanism in medicine, but we also would like to get help. And that's what I think is not really in the construct of what a lot of people think with respect to AI, where you keep hearing about how radiologists will be replaced and how all sorts of disruption will occur. But in fact, our thoughts are very different. That in fact that we see the leaning on machines and outsourcing many tasks to patients who are eager to take on more responsibility. So perhaps we can get started with, there's been a lot of erosion of the human aspects of medicine over decades. What's your perception about that?
Well, I think, first of all, I think we're extraordinarily lucky to be living in the day and age that we are. I mean, I was attending this morning's session and like many of you, just stunned by what is there, what's coming down the pike, and also recognizing that each of these will present its own unique challenges, as people have pointed out, both ethical challenges and also challenges that are quite unanticipated. And the one I think that you and I relate to the most is the electronic medical record. At one level it seemed like the most natural and brilliant thing to do, that we should have electronic medical records, and I certainly don't want to go back. But the one that is presently in use, or the one or two big systems that are in use, are really, epic failures, if you pardon the pun. We have wound up with the situation where we are the highest paid clerical workers in the hospital. And we're spending 1 hour on the computer for every 1 hour cumulatively that we spend with the patient. And I think that single invention, if you like, has been responsible for more distress than almost any other thing that has happened in modern medicine, quite apart from the pace of medicine, the data, the fact that we are chained to that machine. So I think very much like that, almost everything that comes down the pike requires its reflection, requires us to try to anticipate as best we can. And I think that is the challenge, just as much as the challenge is to develop new technology. The technology is parallel with that to address the human aspects of what this means for the patient and for the workforce.
Right. Now, one of the problems besides the electronic health record, which I think this demotion to data clerks for clinicians, which has been a big part of the burnout story. And of course, it's not just burnout, as everyone here recognizes, it's clinical depression and even the highest rate of suicides throughout the medical profession in history. We can't attribute that all to electronic records, but part of it also is the lack of ability to provide care. Because not only is there this saddled with this keyboard and data clerk function, but there's very little time with patients that is true presence. Actually, I know you built a whole program about presence at Stanford, so maybe you can talk to that.
Well, I was struck by the fact that when you talk to patients, the one thing that they complain about is that we are not present with them, that we have one eye on the keyboard and we're distracted. And ironically, when I talk to physician groups, that is the very thing that they complain about too, is that they're not allowed to be present. And so we began this center at Stanford called Presence, and one of our projects has been to really try and hone in on that first moment when a patient meets a physician or a physician meets a patient. And there are thousands and millions of such moments happening every day, a first meeting between two strangers in this context. And one of the things we wanted to do was, how can we best make that first moment happen well enough that everything that follows happens well too. Milan Kundera, the novelist, says that the first moment between a man and a woman predicates everything that's going to happen. I don't know if that's necessarily true. I do think it's true with the patient-physician relationship. If the connection isn't ideal, then everything can fall apart, from compliance to even hearing what's being said. So we've been really trying to study that, and it represents just the kind of thing that isn't necessarily sexy for technology, but its effects are huge. But I want to turn that back to you, Eric, because part of the problem has been the loss of autonomy. We have not been able to dictate our work, our work style. Rather, it's being dictated for us, how many people we should see and so on. And if you don't know it, I want to point you to a wonderful article that Eric wrote in the New Yorker not too long ago, talking about the business of, we're 1 million strong, and yet we don't speak as one voice. Would you tell us a little more about that?
Right. So that essay was in August, Should Doctors Organize? And basically what it's about is the fact that we have the administrator overlords in medicine. And their growth over the decades from the 80s on has been 3,200% relative to 150% in the physician workforce. And so they don't take care of patients. They're not involved in any patient care, but they are ruling the roost with respect to more productivity, more efficiency. And all the things that have happened over these years that include relative value units, health maintenance organizations, and of course, notably, the most recent hit in the 90s, starting in the 90s, but just keeps accelerating, electronic health records, have been supported by the administrative side, not the physician side. There frankly hasn't been a voice for physicians because the largest organization, American Medical Association, barely has over 200,000 of the million doctor workforce in the United States. And the other problem, of course, is all the other professional societies are much smaller, with the exception of the American College of Physicians, and they are balkanized. So they're all just subspecialties or disciplines. And for the most part, they don't really stand up for patients, but rather they are really trying to ensure reimbursement for physicians and the business aspects of medicine. And the term trade guilds comes to mind for many of these societies. So what we do need is a way to stand up to our overlords who are essentially making this problem very serious, because we are facing the greatest opportunity in healthcare and medicine, perhaps not just for this generation, but for many. And that is that we, being able to have the gift of time, which is afforded by being able to rely much more on machines to process data, to liberate from keyboards, from natural language processing and machine learning, and also, as mentioned, to get patients to take more charge. That could give this gift of time, but it will just be used by the administrators as a way to increase productivity and make even worse the squeeze that is occurring right now. So if we don't stand up and have an organization that takes this on, we'll miss this opportunity. And so that organization is going to take hold in the weeks ahead. It's actually called the Osler's Alliance. And I didn't know in writing the essay that there would be a strong support and really robust enthusiasm to build this. So hopefully we will get as many of the million physicians involved, and as a byproduct of that gravitas of having the voice of physicians to stand up for things like the patient-doctor relationship.
And I think it brings us to what has been the most important, discovery we've made in this podcast is how much that time with the patient translates into meaningful results, meaningful efficacy. So we had the pleasure of talking in one of our sessions with Alia Crum, who does a lot of work on placebo and nocebo, and I thought it was a very, for me, an eye-opening session, because she has a little lab where she does nutritional surveys and research. At least that's what students think at Stanford when they walk into the lab. And as part of that survey, she injects some histamine into the skin. It produces a circle of red erythema, which you can measure. And she's been able to demonstrate that after that, a nurse comes in and rubs an inert cream on a nurse type, and that nurse type can either be someone with a very warm affect, how is your day, how's everything going, oh, I love that blouse, or they can be all science and business, and it changes the diameter of the skin reaction. I mean, this is not entirely new. We've understood for some time that when you give someone a placebo, you're not tricking them. You are, when it works, which is about 30% of the time, you're producing a discrete neurobiological change. And I think we haven't quite done enough to tap into that. And one of the things that Alia and other researchers like Benedetti have shown us, that you can have a placebo without a placebo, meaning your tone of voice, the affect, the setting, the degree of your perceived interest, the time you spend, all have significant therapeutic effects. And I actually think the time will come when we'll have to do placebo-controlled trials with a high placebo and a low placebo arm, because we haven't really controlled for the human element. We just give pills, and sometimes the differences are masked by the degree of the researcher's personality.
Right, and actually, Alia, after that podcast, a week or two later, there was this remarkable study published in Nature Human Behavior where they took dyads of a doctor placebo. They actually were students, but they were playing the doctor and placebo. And they showed that just subtle facial gestures, transmitted amazing amount of power to placebo or lack thereof. And so this idea about presence is so many aspects of it. But one of the other discussions we had was with Danielle Ofri, who is at Bellevue in New York City. And we had a rich conversation. In fact, we had to split it to two episodes because there was so much there. But she actually talked about the physical exam, which I know, in fact, I was thinking about how the radio show, Car Talk, that used to be, that might have been one of the original podcasts, but the radio show. And it was click and clack, and you're kind of click because you're a great emphasis on the physical exam over the years. But she brought up the important aspect about how that exam, that people want to be touched, have an exam, and how that is another part of, a critical part of the present.
Yeah, I think that people want their disease localized on their body. Yes, it might be a biopsy report, it might be an image, but ultimately I think there's something deeply symbolic about, the exam and localizing, touching where it hurts, so to speak. And from my colleagues in anthropology, I've learned that when we do the exam, it actually has all the trappings of ritual around it. I mean, if you think about it, one individual is coming to a stranger and they meet in a room whose furniture doesn't look like the furniture in your house or mine. And one is wearing a white coat with shamanistic tools in the pocket, and the other is wearing a paper gown that no one knows how to tie or untie. And then one person proceeds to tell the other things that they would not tell their rabbi or preacher, in my case, in my specialty, infectious disease, things that they would not tell their spouse. And then, amazingly, at some point, one member of this dyad disrobes and allows touch. It's a profound moment. It's not something in any other part of society that would be assault.
Right.
And I know there's been some confusion about this at the very highest levels, but it is assault. But in the context of the fiduciary relationship we have with our patients, in that moment, it is a profoundly important ritual that we are allowed to do in that setting. And I think that my anthropology colleagues have taught me that rituals are all about transformation. We engage in rituals like, marriage ceremonies and baptisms and installations to signal the crossing of a threshold. And this ritual, with all its trappings, is something that patients from every culture, they know about ritual. And if we, have the trappings of the ritual, but just do a half-assed prod of the belly and stick the stethoscope on the paper gown, they are onto us right away. They're onto us just as you're onto the sloppy barista or the hairdresser who doesn't know what they're doing. We may not know how to do what they do, but we understand when it's done well. And so I think my belief is that there is this timeless aspect of medicine that no amount of technology can completely take away, which is the need for this human being who is, the face of care, to do it with some skill.
Right. And I couldn't agree with that more. And the whole point is, we talk about AI, which has already been seen through deep learning to improve image interpretation, much higher accuracy at high speed, whether it's radiology or pathology slides or electrocardiograms or soon ultrasounds, and the list just goes on, skin lesions, and even colonoscopy. And that's, in fact, the first randomized trial to show not only picking up polyps, but now the idea of being able to tell whether they're cancerous or not in real time by machine vision. But putting all that aside, the greatest gift that AI can get us is to go back to the future, to get us to the humanity in medicine, which is present, which is a physical exam, listening, to build the trust and communication and this deep empathy. So if we don't seize this opportunity, it seems like, if we just focus on what AI can do with respect to technical aspects, we're missing out, don't you think?
So I think that was the epiphany for me when I read your book, Deep Medicine. There was a moment in the book, this beautiful book that catalogs all these mind-blowing advances, many of which, I continue to hear about here. You had a graph, a very simple graph showing the machines, progressing in their capability. And then there was this moment where you said, basically, machines are better than us. They can process more images than we can ever do. They don't get fatigued. They work night and day. They can assimilate more data than a human physician can hold in their head. But then you came up with this extraordinary comment at the end of the paragraph that since machines have now eclipsed us, so to speak, this is the moment where we can learn to be more human. That aspect of medicine that involves us, this is our moment to take that further. And in my mind, exponential medicine, if it focuses only on the technology and misses this, isn't being exponential enough. I think there's a huge, avenue there, a whole new realm of exploration that we're just beginning to tap into.
I think that says it well, because we have a situation where we're so interested in technology and we seem to focus much more on the short-term benefits. Whereas here, we're looking at something that could be transformational to get medicine the way it used to be. When I finished med school, around 1980, it was a very different, the time we had with patients. The fundamentals of how important the physical exam was, whether it's in the hospital setting, the bedside teaching, or the communication with patients was very different. It wasn't down to 7 minutes. And it was the essentiality of that human connection was there as a routine. The reliance on this precious relationship. The question is, can we get back there? And are we seeing the tools emerge that will make that
and just to be
possible?
clear, I don't think we want to go back to science in the 1980s
No,
because
no.
many of the patients that we cared for died for lack of what we now take routinely. But we do want to go back to some element of caring that I think we have lost along the way. One of our guests last session, I think, was Arthur Kleinman, a very distinguished professor of medicine and anthropology at Harvard, who trained Paul Farmer and many, many other sort of wonderful physicians who have their hands in both the worlds of anthropology and medicine. And he wrote this very poignant book about his wife getting premature Alzheimer's and dying. And it's called The Soul of Care. And I think the most damning thing that he said that really shook us was that 99% of what she needed wasn't going to be supplied by healthcare. So that word healthcare becomes almost ironic, because the care, in that prolonged illness was him, day and night. It was his children. It was caregivers. It had nothing to do with us and all the science. And I think, if you look to the future, she had Alzheimer's prematurely, but we do know that by the year 2020 we will have a big percentage of Americans who are older. By the year 2050, the proportion of people over 85 will be huge, and a quarter of them will need help walking. A quarter of them will need help in dressing themselves. Half of them will need other sorts of minor help in activities of daily living. And I think that that's where a lot of our energy might go, to prevent that and to come up with technologies that allow us to be autonomous at that stage as best we can.
Right. I mean, that's another important direction where this technology that's being discussed, much of it at this meeting, can help. No, I think this is Arthur Kleinman's, the father of medical anthropology. He's written 40 books. But the one that hit me the most was the essay he had in The Lancet just several weeks ago, The Soul of Medicine, and his outpouring about how medicine has lost its soul for the reasons that we've been discussing, and we need to get it back. And we can. I think that's the most exciting thing about where we are right now, that is looking at a real exciting potential. Let me turn this off.
Speaking of technology.
Technology, great. Another marketing call. Yeah, good. So,
one of our challenges, I think, is to make this sexy. How do you make the human aspect of medicine of interest to entrepreneurs? How do you make it of interest to the kinds of folks who come to this kind of a conference? And I'm reminded of the word evidence-based medicine, which was a science that became popular because of Alvin Feinstein, who was an extraordinary clinician at Yale. And when he made that term, or when what he did was labeled evidence-based medicine, he wasn't talking about taking data and mining it. He was really talking about taking the evidence from the patient, using a skilled physician, and making that the basis of some of the decisions. And so we've gotten very far away from that, where we think the only data that's any good is the data that's printed out, and the other data we simply ignore. We have this wonderful ontology for disease. You can have a disease and I can give it a number. I can tell you whether it was the left side or the right side, acute or not. But we really know nothing about the patient beyond this 47-year-old white male came in with chest pain. And yet there are reams of facts about their life that they possess, that perhaps is on social media, that I think we can do a much better job bringing to the people caring for them. Great avenues for research, in my mind.
No question. So just to sum up, a lot of the progress that's been made in AI in the medical sphere has been reported out as that there was outperformance by the algorithm, by the neural network, by whether it's in pathology or radiology or whatever the field. And very little has been, well, what happens when you put these two together? And there hasn't really been anything yet to study what we're interested in, which is how to make the communication, the bond between patients and doctors better. And that's something that we hope to see in terms of the research going forward. Well, why don't we go ahead and open it up to your questions? We've been rambling a bit, and now we can hear what you have to say and what you're thinking about in terms of how do we get the symbiosis achieved between medicine and machines in the future.
Thank you very much. Thank you. We live in a fee-for-service system, which the physician gets money as long as they have too many patients. So he has to be fast, and he has to demand exams and so on. So how can you balance this thing that medical reimbursement and humanization of medicine?
Well, I think one of the issues here is that we don't assemble a patient's data very well. Right now, we have a problem. No patient can get all their data, especially in this country. And so if we could take that data and organize it and integrate it for the patient, they would know more about what should and shouldn't be done for them or to them. And that is essentially the virtual health coach concept that eventually we'll see. It's starting to take hold in particular conditions like diabetes, but still in the very early stages. But once we get multimodal data organized, both on the physician and clinician side, as well as on the patient side, hopefully we can see a lot of the waste. I think most people here are in touch with the fact that out of our $3.6 trillion a year in healthcare in the US, anywhere between a third and a fourth is waste. No less all the things that induce incidental findings, which rabbit holes that lead to complications and unnecessary expense or inappropriate testing. So if we have both parts of this dyad charged with data, which people can't get their arms around the data, there's so much and it's diffused on many different places. If we start to see that, and using hybrid models, not just deep learning, but other models that are being developed, we'll hopefully have an antidote to this problem.
Yeah, I think there was this beautiful editorial by Don Berwick talking about this waste, accompanying the paper that described the magnitude of the waste. And he talked about it was like the Fermi effect, where you knew there was waste, but you could never seem to pin down where it was or do anything about it. It was like fat marbled through the steak. You couldn't quite have the steak without the fat. But I think that's a challenge to all of us. I think there is a better way. I think I should say, though, harking back to your New Yorker paper, in many ways the reason that we're fee-for-service and being pushed like this is we gave away the reins. Every one of our societies that we belong to was campaigning for more money, was campaigning for more protection, was in the business of getting more for their procedure. So at a certain point, I think big business just took over. It became absurd. And it's still absurd. I mean, the percentage of our GDP that's going to healthcare, I think, is just not sustainable. So, where is our charge in that? I think it begins with speaking as one voice. So I think Eric's paper, this idea that we are 1 million strong, and if we actually got together, and there have only been a few instances where we have gone on strike in this country. Isn't that right? And you were a witness to one of those, I think.
Well, it's a really good point. Only recently, in the times where going against the NRA, when they said that doctors should stay in their lane, and the response, which was extraordinary about this is our lane, but also many other matters where physicians have had a voice for the first time, a very resounding voice. And so we're starting to see it's often the young physicians, often female physicians, that are taking on this charge. And I think it's terrific, and it's a sign that we can unite, and hopefully we'll achieve this. But to the point that Abraham's making, the fee-for-service world that we live in and will continue to live in, despite all the different proposals that are being put out there by the candidates for president. This is a problem as an outgrowth of lack of a voice, for sure. I'm certain of that. Other questions? Yes. We have a
microphone's there, and then next here.
Yeah. Okay, go ahead, and then we'll get you next.
Hi. My question is, what other industries do you think that we should be looking at? Because, to be honest, there's industries such as aviation that have actually gone through this. They've had the hard times. They've created this really good symbiotic relationship between technology and the human being, which has led to improved safety. Where are the key industries that you're looking at to help us learn on this journey?
Well, I would just put out the two what I think are the biggest opportunities in healthcare today. The first is the elimination of keyboards, the liberation from keyboards, the common enemy of both patients and doctors. And there are at least 20 different companies, from the tech titans like Microsoft and Google to lots of different startups. And it's kind of funny to say that after the video that Daniel showed. But the fact is that you can have a synthetic note that's far better than the epic Cerner notes, just from the conversation. It's already been proven. It's already being adopted in certain places around the world, or piloted here, even in the United States. If that is developed with serious, validated, how the notes are better, and of course that comes in the face of the fact that by the end of next year, at the rate things are growing, we'll have 100,000 human scribes in this country. Pre-Gutenberg. I mean, it's incredible. 100,000, and we keep on throwing more human capital at our problem when we can rely on algorithms. So that's one. And the other big one in healthcare that I think hasn't even been touched yet, but is just waiting. So regarding the cost of healthcare, the number one item is our hospitals, accounting for a third of the 3.6 trillion. And in those hospitals, it's the labor force, the workforce. Now, we don't need hospitals, except for intensive care units, emergency rooms, operating rooms, and a few other assorted small things to support those entities. All the other rooms should be the patient's bedroom or home. Now, we have the technology to do that today and build the algorithms to validate that home monitoring is as safe or better than hospital monitoring. And in fact, you could put all the sensors and all the algorithms out there, it would be still far less expensive, and data plans to forgive a person, they'd be still cheaper than one charge of a night in the hospital, which is now $5,000 in the US average. So these two are so big because they have not a humanistic side in terms of the presence. That's a technology solution, which a lot of people don't understand and buy into, that using technology can enhance humanity. It's seen as a non-intuitive aspect. But both of these, what would be better for a patient, to be in the hospital, where they have 1 in 4 chance of having something happen bad to them beyond nosocomial infections, or actually being in their own bedroom with their own family? So these are things that we should push on, but we're not at the moment, neither one of them are aggressively being pursued.
And just to follow up on that, you mentioned what industries can we borrow from? We've certainly borrowed from the airline industry with concepts of safety, but I don't think we've borrowed quite enough. I mean, if you look at the Boeing cockpits, it is designed entirely for the safety of the passengers and the ease of the pilot flying it. Any alarm goes off, it doesn't go off randomly. There's always a reason for it, and levels of alarms that you have to address. The average nurse in America, in the course of a week, hears something like 100 alarms going off in our work. And what do you and I do when we walk into a room and we hear an alarm? We just try to find the button to turn it off. I mean, so we haven't begun to tap into the kind of sophistication that the airline industry has demonstrated for us. Or, for example, the banking industry. I can use my ATM, and I did this morning at an ATM far from home. I could do it across the world. I cannot get my electronic medical records across the street. And so I think we have these bottlenecks and great examples of what we might do, but we're not quite there yet.
All right. And one other last point regarding other industries, because I was speaking more within our industry, but the driverless car. And that's, I think, the parallel here is the doctorless patient. We're never going to get to that point across the board, but there are things that are going to be routine matters like a skin lesion, a child's ear infection, a urinary tract infection, a lot of the common things that we can go doctorless. And it's already being done, and as you heard already from a presentation earlier this morning, and a lot more of that's coming. So we're never going to get to level 5 of the Society of Automotive Engineers, which is complete autonomous driving all the time under any conditions. But we can get to a level 3 in medicine, where we actually do promote more charge for patients who want that. And I think that's something that will enhance the efficiency and also the ability for the charge of... Medicine is incredibly hanging on to paternalism. And that's another thing that we could give up and be advantageous for patients. Your mic isn't working?
Can I go ahead with my question?
Yeah, sure. Where are
I
you?
do a lot of work with medical students.
Where are you?
Right here.
Oh,
Okay.
great. While we're fixing the mic
Medical
here, yeah, go ahead.
students. I'm struck by the fact in the last few years, when match day comes, the eagerness of so many in the upcoming classes of physicians wanting to go into ER medicine. ER medicine is such a hot field now, and when I talk to them about what attracts them into that field, I find it in a way very discouraging, because the responses I get, and I don't know if you've had this experience, revolve around shift work and not having to be called or be responsible once they leave the hospital. And also even acknowledging they don't want that long-term continuity of care with the patient. And then I find this kind of an omen maybe of us not doing our job correctly, of being influenced by Grey's Anatomy and having this generation of millennials that are now the new generation of doctors saying that's the kind of doc I want to be. So maybe that's telling us we have to get more proactive in having more media attention, more programs, entertainment programs that depict the kind of the doctors, humanist doctors in an AI world, which is possible. So if you can show them what's possible, that would be something that they would choose as an alternative also.
Well, maybe I can start with that. I think it's interesting that you mentioned a TV show, because I think a generation of physicians of our age came to medicine because of a book, and that book was, in America, it was Aerosmith, or microbe hunting. Elsewhere, it was The Citadel in the Commonwealth. And I'm not doing this for any other reason, but because of your question, I wrote a novel called Cutting for Stone, and my singular goal was to capture the imagination of a college student or a student who would say, I want to go into medicine, I don't really care about reimbursement, but I see it as this incredible adventure, a romantic pursuit, and I still value that more than any prize when I get a letter back saying, that book took me to medical school. I would just say that I don't think it's fair to the medical students to fault them for their choices. I think they're much smarter than we are. They come to medicine with this incredible ability to imagine the suffering of patients. They come for all the right reasons. And the reality is they look around, they see freestanding oncology clinics, freestanding cardiology clinics, short stay surgery. Have you ever seen a freestanding geriatric center with valet parking and a concierge? So we have our priorities wrong. I would actually say that to go into primary care requires a kind of heroism that many of us lack. And so, in a way, they're gravitating to things that are reimbursing well, that are controllable, or the stress is livable, because they see the reality. So I think the challenge is on us, really, within the system, to lobby. Again, back to I think you have to run this union for us, Eric.
No, I'm not going to do
challenge
it.
Is to,
it'll get done.
The challenge is to reimburse primary care at the level that we reimburse, cardiothoracic surgery or what Eric does. And that's going to take some time coming. Thank you.
Thanks. Yeah, I totally agree with that answer. Let's go to you. The microphone working now?
I'm afraid my microphone isn't working, but it is now.
Yeah.
Thank you. Hi, I'm a soon-to-be replaced radiologist based in Auckland.
Not really, though.
Just a couple of things, a couple of comments. One of the areas I subspecialize in is neck radiology, head and neck radiology. I've performed many thousands of neck biopsies, and I've very, very, very rarely used local anesthetic. And it's something that I used to just do intuitively, and I take a lot of time to speak to the patient beforehand. And as you alluded to, it's that human connection that really changes this. I wasn't taught this in medical school at all, though. And just another point underlying the previous question. How much of a problem do you think it is that in order to get into medical school, the main criteria is actually academic excellence?
Right.
Yet we see that barrier often has a disproportionate representation.
Yeah, I'm glad you asked that, and it does connect very well with the previous question. That we do select medical students in this country for their grade point average in college and their medical college admission test. By and large, they have no interview. And so basically on these criteria, it's quite robotic. It's not at all humanistic. In the future, if we really want to do this right, we would be emphasizing those qualities, not so much these grades and contrived scores on a test. Because even though today most people who go into medicine truly would like to care for patients, we could even amplify that. And the ability to do that, leaning on machines to do more to help, as well as getting patients more involved in their own care, will enable that. So I'm hoping that the brainiac syndrome which we have today, there's no reason we don't want very intelligent people in medicine, but we also want the ones who exude empathy. And I think we can do that if the problem we have in this country, we have 150 medical schools, and to change anything is really, really difficult and slow.
And I might say, I don't understand who died and made organic chemistry the barrier for becoming a doctor.
Right. Yeah, really.
And one more thing, I heard someone say that AI is not going to replace radiologists. It's going to replace radiologists who don't use AI. So
yeah, it's
have
true.
heart.
It's true.
Is it on?
Yeah.
Thank you very much for your insights as a full-time practicing doctor, a surgeon. I am living in this age of reimbursement and RVUs and administrative push to get us to do more with less. I really appreciate this trend, this wave of bringing humanity back to medicine. Your book, Dr. Topol, both of you, really eye-openers. And I always remind my students to not forget to read those books as textbooks of their medical career. My question is, what do you think? And going back to your article in August, Dr. Topol, and the 1 million doctor movement, what do you think is the role of the patient? For me, 1 million versus 7 billion patients pushing for this to be flipped into, when you go to the doctor, you got to demand that they look at you and they are, human in front of you. And that they forget the damn computer and use either a scribe or an AI scribe or a Augmetics type scribe, with Google Glass in India, looking at the actual interaction. What do you think the role of patients is? And I really believe, passionately, that we need to spread the word among patients for them to rebel against the type of medicine that we're practicing in the 21st century.
Yeah, well, it's a great point, and the hope is if we get physicians to organize, that would just be the first front for this. And eventually, not just patients will be clamoring for the time and for this relationship, but we'll also start to see for the first time health systems competing that we give the gift of time for our clinicians and patients. That would be the ultimate, instead of competing today for things that are not really important as that.
Yeah, I think it's a wonderful way for us to wrap up, is to bring it back to the patient, because, I mean, everything that we're doing is really for them. And I think we need to keep in mind not what we could do for them, but what we should do for them. And I think too much of our sexy technology is often wrapped around what we could do, when I think the more challenging question is, what should we do, and how do we bring that about? But thank you so much for that.
Well, and thank you all for the Medicine Machine, our first live podcast, maybe our only live podcast. Thanks for having us, and hope you enjoy the rest of the Exponential Medicine. Thank you.
Please.